Elston's Tuesday, is that his or ours? It says continuity. Is that ours?
They're under us.
Okay.
Depends on how you define it, though.
I just wanted to okay.
So, good morning, everyone. And for those joining us remotely, we are doing the second session of epithelial tumors, so focusing on the malignant epithelial tumors. So, it's Tiffany, right?
Yes, sir.
Okay. Do you want to start out?
Sure. So I'm seeing pretty thin cortified layer, the 3D ridges are, some of them are a little elongated or jagged.
Yep.
And then there's the stroma in the 3D, in the dermal papilla is a little bit loose.
Okay.
Then you see this pagetoid spread of some cells.
Yeah, there's a buckshot scatter or pagetoid spread. Why is it referred to as a pagetoid spread?
Because it resembles paget.
Because it's what you see in pagets, yes. So pagetoid or buckshot scatter spread can be seen in melanomas, can be seen in pagets, can be seen in Bowens. So of those, which do you think this might be?
I'm thinking this. I'm leaning towards melanoma here.
So melanoma would certainly be one thought. How would you?
We'd have to do stains.
Yeah, exactly. So and you see cells that have an ample amphiphilic cytoplasm. You look for some features like crushing of a basal layer. Do you see that anywhere?
I guess it is kind of crushing, so that would, if it is crushing, it would lean away from melanoma, but I honestly can't tell very well.
Yeah, you sort of have this row of nuclei below the abnormal one. And again, here, that counts.
Okay, so it's not sort of going to be likely melanoma.
Another one there. So less likely melanoma when you see that. But you can always confirm with immunostains. So what do you want to order?
So I guess I would order like a SOX10.
So SOX10 would be great for melanoma.
CEA.
CEA would be great. And that would probably be adequate.
Okay.
CK7, everyone was super enthusiastic about CK7 until Klaus Helmut Hershey actually looked at Bowens with CK7, and it's very commonly positive. So CK7, which was everyone's favorite, boy, it looks really specific for Pagets, does not appear to be that specific for Pagets if the differential is Bowens. So, okay, it's very nicely done. Okay. So Shane, what do you see here?
Well, let's see Pink Strands with a very,
Anastomosing Pink Strands.
or maybe ducts inside.
There are some ducts inside.
So, this would be what I would be saying.
So you said pincus? Okay, very good. Yep. So pincus tumor, anastomosing pink strands, blue buds at the tips. It surrounds a fibromyxoid stroma, which is why it's called the fibroepithelioma of pincus, but it behaves like a basal cell. And there typically are eccrine ducts in the pink strands, as he pointed out.
I'm seeing it's a very pink stain slide. Not really seeing a lot of metoxin staining, but it could just be that it's an older slide. The quantified layers look a little compact. The thickness of the epidermis looks okay, although kind of in the center you're seeing maybe some palisading and maybe some retraction around that palisading. So even though the staining isn't appropriate, I'd probably have to go with the basal cell.
Yep. And now tell me about the margin of the basal cell.
So normally with the basal cell, if you have that fibroid myxoid stroma to the margin, then it would be positive. So
yeah. So your point is beautiful that you're looking at not just tumor, because this is a superficial multifocal BCC. In 3 dimensions, it's like a garland, but in 2 dimensions, it looks spotty and multifocal. And so you follow the stroma to the edge. In this case, the stroma probably ends about there, so we're fine on this edge.
Very good.
I would call this all K.
Okay, so why keratoacanthoma?
It has a nice, you can see underneath it, it's well defined, the buttresses are normal epithelium, there are some neutrophil abscesses in there, it's not acantholytic, it's,
So crateriform, no acantholysis, which is important because that's an absolute disqualifier for Ka. Hypergranulosis is where? Towards the center of the lesion, whereas in squames, hypergranulosis is only at the periphery of the lesion. So hypergranulosis in the center is good for Ka. What are all of these little amphiphilic areas here?
elastic trapping.
Yeah, trapped elastic fibers. So it's been said that squames push their way into the dermis, Kas pull their way into the dermis along elastic fibers. So that elastic trapping is characteristic. As you pointed out, the neutrophil microabscess. If you looked higher, what kind of inflammatory cell might you see in the infiltrate?
Yes.
Lots of EOs are usually present. Plasma cells more likely in squame. Eosinophils typically present in keratoacanthoma. So crateriform, eruptive growth begins with hypergranulosis in hair follicles. Those hair follicles expand, become glassy, merge together into the crateriform lesion, pulling itself along elastic fibers, so that you see amphiphilic elastic trapping throughout the lesion. Okay, very good. And how'd you treat it?
I would inject it with some 5-FU.
So it kind of depends where it is and how rapidly it's growing. On a trunk or extremity, often we just cut them off.
Honestly, with that one, you got underneath it. Do you really think you need to treat it at all?
If
Like
you're
the
underneath it, you may not
the
need
shave
to
fire-
treat it at all.
okay, got
Point
it.
well taken.
Dr. Elston,
Yeah.
that was read out as crateriform squame. Would you ever ED&C those? Like if it was on this one?
So electrodesiccation and curettage you can do. They're often not as curettable as a basal, because a basal cell produces its stroma, grows within its fibromyxoid stroma. Your curette kind of stops when you hit reticular dermis. A Ka pulls itself along elastic deep into the reticular dermis. Not as reliably curettable, not as good a cure rate as for a basal cell. And curettage for basal cell is 80%, so you're significantly lower for Ka. So I'm more an excision, which could be saucerization, or you can do 5-FU or methotrexate injections if it's in a more problematic area where surgery may not be in the patient's best interest. Okay, James.
Yes, sir. So, from I would call it like invasive squamous.
like invasive squame. So why would you call this invasive squame?
There's like large atypical keratinocytes without a well-maintained DIGE.
So you are correct. You can see that they're keratinizing cells, and they extend down into the dermis. There is significant atypia, and it's not surrounded by a basement membrane zone. In fact, it just keeps on going down to the base and becomes a spindled squame. So towards the base, you still see some atypical cells, but most of what appear to be fibroblast nuclei here are probably squamous epithelial cells that are likely to be positive with immunostains. So what immunostains might you choose to use?
Like pan-keratin.
Like a pan-keratin, what else?
Other keratinocyte stains.
Other keratinocyte stains, yes.
I don't really know other ones.
So, anyone want to jump in with what other ones?
63.
So P63, excellent, which is a nuclear stain, which is much more specific. P40, which is a subtype of P63. AE1, AE3, which is a mix of high and low molecular weight keratins, or keratin 903, which is high molecular weight. CAM 5.2, which is just low molecular weight, we'll probably miss it. That's for more anaplastic tumors that sometimes just differentiate towards expressing low molecular weight. So family of keratins, different uses, all within your scope of practice. So all stuff probably worth reading about. Okay.
So
So Dan.
this is a predominantly small blue cell
Okay.
in the dermis, although some of them seem to come from the epi, so I'm favoring squame.
Yeah, some of them seem to come from the epi, but they're very blue, right?
Yeah.
So very,
The other differential would be Merkel, maybe, but I'm still favoring squame.
so Merkel versus squame. Merkel certainly can be epidermotropic. It does look like it's keratinizing in some areas, very anaplastic. So two possibilities. One would be that it is Bowen's that's become invasive, because Bowen's starts as a much more anaplastic tumor that then can become invasive, or metastatic squame that's epidermotropic. So what appears to be coming off the epidermis might be actually latching on to the epidermis. It may be the other way around. And so this is a patient with metastatic lung that is epidermotropic. So epidermotropic metastatic carcinoma. You know, we can't assume that all squames are primary in skin.
Shave biopsy, there's some degeneration or a lot of papillary edema or fat way up high. Some clear cell change, clear cell.
So if
Maybe
that's
not fat,
clear
maybe
cell,
some clear cell.
so maybe it's not fat. Maybe that's clear cell change.
So clear cell Bowens.
Yeah. So now you start thinking of epidermal tumors, which would be clear cell. Any chance that this is a clear cell acanthoma?
I don't think it's too atypical and it's this irregular.
I agree. There's nuclear atypia, and this kind of vacuolated signet ring type cell you just don't get in clear cell acanthoma. So clear cell Bowens. You'd search for areas with a more typical growth pattern. This one actually was Bury P4 positive, and other areas looked more typical basal cells, so it's a clear cell BCC. But that in clear cell Bowens would be probably top of your differential.
some pagetoid spread.
So you definitely have some buckshot scatter, pagetoid spread in the epidermis.
Lots of atypia, kind of extended downward. I have, looks like maybe some nudes in the horn. Is that nude?
Yep, definitely have a crust overlying.
Right. So I mean, I guess you could think of like a Paget's disease or pagetoid spread from melanoma or.
What's the pattern over here?
Sebaceous.
So sebaceous carcinoma will commonly have pagetoid
Right.
scatter
That
as
looks a little
well.
Sebaceous.
What else?
Um,
Definitely see pink keratinization here, right?
right. Just like Bowens.
So Bowens would be the other thing in the differential. So Bowens, Paget's, sebaceous carcinoma, which grows in a bowenoid and buckshot scatter in the epidermis. So how might you tell them apart if you were going to get stains?
So I guess you would get diastase to tell Paget's and Bowens apart. You mean?
So diastase.
Diastase. S100 for melanoma.
So diastase, you mean PAS with diastase?
Yeah, PAS, yes. Yes,
Okay.
with diastase.
So PAS, where you've digested out glycogen, so all that would be left would be sialomucin in the Paget's, which would remain PAS positive. So that's actually a good histochemical stain you can use. What else?
So for melanoma, S100 is probably advice.
Yep.
Like spread. Sebaceous, you could do, let's see. Maybe for sebaceous. I don't know, blanking, but there's a good stain for sebaceous.
There are.
Somebody knows it. Huh?
EMA is
yes,
one we
that's
use
what I was thinking.
commonly. There are also sex hormone stains that you can use, but EMA is probably most widely used. Many epithelial tumors are EMA positive, but not in a vacuolar pattern. So if you have lots of tiny little vacuoles where the membrane is EMA positive, that's a sebaceous pattern.
So in that one cell you pointed out looked a little sebaceous, but
Agree. And
there's
so you
some-
absolutely would want to stain it. Excuse me. Sorry. Okay, Blake.
So almost see like what I'd call, is that villi? Atypical keratinocytes. Almost like verrucous like.
Yeah, so kind
With
of
the atypical cells, I'd probably say verrucous carcinoma.
so kind of verrucous. What kind of keratinization does it have? Is it keratinizing with the granular layer? Or is it keratinizing kind of abruptly without flattening first?
Pretty abruptly.
And so what you might call a tricholemal keratinization. So let's see, you want to call for a lifeline.
Mm-hmm.
Rob, you want to jump in and help?
So, I was kind of thinking verrucous carcinoma myself. I mean, like I guess a warty disc keratoma would be in there.
So warty D, you'd look for acantholytic disc keratosis,
We don't really
more
see-
clefting, which we don't see a lot of. Anyone else want to
Like
jump
a
in?
squame.
So proliferating pilar cyst, or proliferating tricholemal cyst, which is a big look-alike for squame, often get miscalled squame. The key would be getting a sense that you're looking at a cyst with an infolding wall, kind of a rolls and scrolls pattern. But when only a piece of it has been taken out, can be tricky and benign tumor that often gets overcalled. Okay, so that was a little tricky with its tricky lemmal keratinization. So, Blake, how about this one? Better?
Yeah, I would say looks like a BCC.
Looks like a basal. Okay, so basaloid cells, mucin-rich, fibromyxoid stroma, peripheral palisading,
It's kind of
nodular BCC. Well done. Okay, Brian.
real thick horn. Looks like in areas you have osteal sparing.
Okay.
Kind of gives you that flag sign. It's
So
like
you
the-
got a flag sign,
Mhm.
and in some areas you can definitely see that it relates to the acrosyringeal keratin.
Mhm. Areas it looks like the cells are a little bit jumbled, smaller. They don't look like they go full thickness. I'd favor just a AK or a hack.
So flag sign corneum, usually overlying an actinic, sometimes overlying bones. So you look at the degree of atypia. In this case, a lower grade atypia, so hypertrophic AK sounds just about right.
So you have some clear cell change in the epidermis, some crowding, sort of bonoid.
It's kind of bonoid. How about your basal layer?
It looks like there's a lot of crowding and sort of palisading around.
Yeah. So what you got here is kind of an eyeliner sign, where you have a normal basal layer that's crushed by the expanding proliferation of clear cells.
It looked a little bit invasive over there. I favor right in there.
So right in there, looks like you probably have probably some invasive carcinoma arising from it, but arising from what?
Bowens.
So probably Bowens. And one of the clues is, with all of that atypia in the epidermis, you look at your corneum, there's not, this is the closest you get right here to any of those atypical cells popping out. You really have very few clear cells in the corneum, whereas Paget's, especially and to some extent melanoma, loves to keep its identity in the corneum. So you have cells that remain clear in the stratum corneum. Here, they all turn red because they're all capable of keratinizing. So they can hide in the corneum where you don't see them anymore. So that does favor Bowens. So eyeliner sign you can see very well developed in Bowens, and you can also see it in Paget's.
Okay, seeing infiltrate in the dermis, looks like palisading around some of the areas.
Okay.
I'm favoring a BCC of some sort.
So favoring BCC, and it has these clear spaces, so adenoid, BCC, and then what else about its growth pattern?
Somewhat infiltrated down at the bottom there.
Yeah, is it spiky or more little round to oval islands?
More little round oval islands.
And are they all within a fibromyxoid stroma, or are they between pre-existing collagen bundles?
Yeah, I do see the collagen bundles in between, some of those smaller.
And with that,
It's like a micronodular.
micronodular, and the key is, if it's all within its own stroma, you can define it with a curette. You curette right to the edge of the tumor. In fact, you can curette all the tumor away because of that soft, squishy stroma. Whereas here, in a micronodular where it's between collagen bundles, your curette can't get to them. So they are more aggressive because they are much more extensive than your curette is telling you. Your curette lies, basically, because it's just scraping over collagen, and yet there are all these little tumor islands beyond where your curette is. Okay.
So I got a shave biopsy. Looks like there's some sort of proliferation within the epidermis. You see some large atypical looking cells. Definitely disorganized basal layer. Looks like it seems full thickness to me.
Yeah, and in areas it's kind of clonal.
Mm-hmm.
There are individual little clones sitting in the epidermis, which is something that an AK is not capable of doing. So when you see little clones like that, that leads you more towards bones. This person has hundreds of wart-like lesions in the genitalia. So what's kind of where wart meets bones?
Like a Bruch's carcinoma?
That's one
HPV-driven
variant. So HPV-driven, and so Verrucous carcinoma. In fact, most genital squamous atypical lesions fall into that. But the one I was getting at was bonoid papulosis, where they look kind of like venereal warts, usually a little more pigmented. You can see the pigment within these cells. See all that melanin? So pigmented lesions in the genitalia are as often Bowen's as they are melanocytic. And bonoid papulosis tends to be pigmented, tends to be sessile, tends to be smooth, whereas condyloma tend to be cerebriform and non-pigmented. So those can be clinical and histologic clues to the HPV-induced multicentric nature. Okay, Justin, you want to do this one?
Sure. It has some acanthotic squame appearance, so I'd be favoring so crushed basement membrane.
It's a crushed basal layer, and it's definitely an intraepidermal pattern. So what two things give you an eyeliner sign in crushed basal layer?
Bowen's.
So Bowen's and
Paget's can.
And Paget's are the two.
Stain. The cells are kind of more amphiphilic, so certainly could push more towards Paget's, but then there's keratin formation.
And underneath, keratin looks more squame-like, which leads you back towards Bowen's. If you did a mucocarmine on this, you'd see areas of mucocarmine positivity in the squame. So this is a mucoepidermoid carcinoma that is growing with intraepidermal Paget's. So Paget's can occur on the breast, Paget's can occur extramammary. And it's you. Can you put in your password and lock this down? There we go. And in this case, you've got a mucoepidermoid salivary type tumor growing with an intraepidermal Paget's pattern. Those we'll commonly get when it's from the tail of the parotid. So the most common place that we see that is retroauricular. So you've got a retroauricular ugly squame. It may actually be a primary salivary tumor. That's a place for mucoepidermoid carcinoma.
So in that one, was it more knowing the location, or did you, with the mucoepidermoid,
there were
that
some
one where you get like signet ring cells?
Yeah, exactly. And we had some of those over, especially in this area. You can see these little signet ring, which are amphiphilic. So they look almost like goblet cells, because basically they are almost like goblet cells. So that's one of the clues. So, just like you have to remember Mets, epidermotropic. Mets to skin, they're also adnexal structure tumors and salivary tumors that can connect up with skin and become epidermotropic and grow as paget's.
So there's definitely pagetoid spread here. I've been to even almost being spit out into the cornified layer.
Yeah, these are more spitting out into the cornified layer, which tends to go against Bowen's and towards what two possibilities?
Towards Paget's and, oh gosh.
Paget's or melanoma.
Okay.
And then you see the atypical cells, and you've got some crushing at the basal layer.
So it's more likely Paget's.
So more likely Paget's. So even before your immunostain, you see cells spitting out. They're amphiphilic. You've got crushing of the basal layer. You put those together, you're probably at Paget's.
It looks like a horn cyst.
Horn cyst.
Center.
So, Seb, right? Done.
Or it could be infundibulocystic basal cell.
Or infundibulocystic basal cell, or
That looks like full thickness.
looks like full thickness, atypia, high nuclear cytoplasmic ratio,
Seems like a Bowen's.
like a Bowen's. Very good.
So we've got a thickened quantified layer.
Okay. Sorry.
That's fine. We go down, we see a little bit of keratinization in the center there. Looks like maybe some acantholysis around as well. I feel like the atypia is fairly far off the basal layer, so I'd probably be leaning towards either like an AK or a Bowen's. Some areas look full thickness, some don't.
Okay. You have lots of mitoses. You have cells that are large. Do you see any irregularity of the nuclear envelope?
Maybe a little bit.
Yeah, I mean, to me, they're mainly round to oval. There's a lot of spindling, and what are these world things? Like if you saw them in a tide pool, you'd call them eddies.
Yes, squamous eddies.
So lots of squamous eddies and spindling. So it's an intraepithelial clonal proliferation with lots of squamous eddies and spindling.
Okay.
So what are you thinking? Squamous eddies and spindling, more likely clonal seb or more likely bones?
Probably more likely Bowen's, I
Uh-huh.
think.
So even though it was the first choice, clonal seb.
Okay.
So a lot of things we're looking at are things that get miscalled, and so are important in the differential. So intraepidermal clonal squamous proliferation. In the squamous world, number of mitoses does not help you between malignant or benign. Pleomorphism does not help you between malignant and benign. The single best discriminator is the nuclear envelope. If your nuclear envelope is thick, refractile, glassy, notched, corrugated, that's cytologically a malignant squamous cell. Whereas if they're oval with a delicate nuclear envelope, with or without multiple nucleoli, with or without red nucleoli, with or without mitoses, they still tend to be benign. So lots of mites here, but architecture trumps, and squamous eddies, spindling, clonal proliferation, probably benign.
So the architecture with the acantholysis, I usually don't think of that like
Ah.
being a stem characteristic.
So we're going to go a little higher, and the question is it acantholysis where the cells become round? Or, let's get ourselves, sorry, a little better into focus. Or are the cells stretched out with spongiosis between them, but visible cell-cell junctions still intact?
So it's just a lot of sponge that's causing
So it's just a
everything.
lot of sponge. If you see, you see all those prickle there, all those spines, those are all desmosomes hanging on for dear life. So there's no acantholysis there. There's just edema between the cells. One of the hints is the cells were spindled. Hard to get a spindled acantholytic cell,
Okay.
right? They tend to round up when there's acantholysis. So, stain not perfect, and I used to throw out every slide with an imperfect stain. The problem is that real life has lots of imperfect stains, so that is within your scope of practice, so it is tested to look at less than perfect stains because that's a measure of your competence to practice. So I keep some of them in now.
I think it's Paget's.
I think it's Paget's. Why do you think Paget's?
Well, it's got pagetoid scatter. They go up high into the cornified layer, and if you look below when we were doing scanning, it looked like there was more smooth muscle underneath. So I figured we were probably in like a genital region or a breast region, depending on.
Yep, very
area.
good. So you have large amphiphilic cells, buckshot scatter in the epidermis. They tend to retain their identity, and you're on what looks like anogenital skin with lots of smooth muscle bundles. So probably Paget's. Okay, James, what do you think?
Like SCCIS.
Like SCCIS. You got a little bit of an eyeliner sign. You certainly have pagetoid scatter and intraepidermal nesting. Overlying, you have a parakeratotic corneum, and the nuclei are very large and hyperchromatic, telling you that the atypical cells are capable of keratinizing and keeping their atypical nuclei. So you're correct. That's a Bowen's feature. And for most of these, part of that is cost-effective medicine. You're not going to order immunostains on most of these, okay? Because you can call them on H&E.
This looks like an infiltrated BCC.
Infiltrated BCC becomes spiky, loses its amphiphilic stroma, develops a more fibroblast-rich eosinophilic stroma. Fibroblast-rich stroma, which we'll find next week, goes very much with pilar-type tumors. So how do you tell the difference between a trichoep with a fibroblast-rich stroma and an infiltrated BCC with a trichoblast-rich stroma?
I can't remember the name.
So there are other features like papillary mesenchymal bodies and things that you look for in the stroma, but also the spiky outline. There is no such thing as a benign spiky pilar tumor. If you just remember, spiky things will hurt you. Spiky outline in a basaloid tumor with fibroblasts is basal. So no spiky benign adnexal tumors. Okay.
Looks like a cyst in some areas. A lot of fibromyxoid stroma on the
So fibromyxoid stroma, inflammation.
The stroma kind of looks like a fibroepithelium pincus, that kind of stroma, but I don't see a lot of the strands. This big cyst.
And is it 3 cysts?
So it could be a resolving KA.
That's exactly what it is a resolving KA. So what you have is a big crateriform lesion making lots of keratin, and the wall is down to the skinny little squamous epithelium, but it still has its crateriform scalloped outline. So that is regressing keratoacanthoma. And one of the hints often present is there's still elastic trapped in the wall. Right. So it still has elastic trapping from when it was in its proliferative phase. So regressing keratoacanthoma, remember, KAs are basically squames capable of keratinizing themselves to death, and you can trigger that keratinization with things like 5-fluorouracil.
So it looks like kind of some crowding at the DH, and not quite full thickness though. So I would say, I would probably be more in the AK range.
So not quite full thickness.
And to me, some of those areas look normal at the top, but then other areas were approaching full thickness.
And in some areas, hypergranulosis, your horn is a compact horn with little cookie cutter holes, kind of like a wart. So
is this more of a...
Probably an HPV-induced Bowens. Okay. And HPV-induced Bowens, genital Bowens, tends to look different. The cells are smaller. They're less atypical. These are commonly missed and not called malignant at all because they tend to be small cell Bowens. So unique look in the stratum corneum is one of the hints. The cells tend to be small but hyperchromatic, and that's another one of the hints. Okay.
So I'd say like small islands, blue cells.
Are they blue or pink?
I'd say pink.
Yeah. I agree with you. I'd be right there with you. I'd say pink.
I mean, first thing that comes to mind looks like maybe infundibulocystic BCC.
Like infundibulocystic BCC, which is pink strands, blue buds, and sometimes the blue buds are not present. It's just pink strands. So the point is there are red basal cells. You think of basal cells as a red tumor except for the ones that are pink. Right? And the ones that are pink are the pincus and the infundibulocystic that are pink strands, blue buds, and sometimes you don't have the blue buds, and yet you have to recognize it because it's going to behave like a basal cell. So pink strands, horn cysts, radiating outward from central follicular-like structures is infundibulocystic BCC. Good.
Very ugly.
Very ugly. I hope it's the slide you're referring to. Go ahead.
So, looks like you got some atypia throughout it, but they're they're blue but very pale cells. It looks like it's preserving the DEJ for the most part, kind of smashing up on it.
Yeah, so you have a crushed basal layer eyeliner sign.
Mm-hmm, and then you've got a little interface dermatitis as well along it. Seems to go full thickness there in the center, but then it looks like it's sparing some other areas.
So what's your differential?
Put it in the Bowen's category. It's
So
got the
Bowen's,
clear cell
anything besides
change.
Bowen's?
With the Pagetite could be melanoma. Paget could be.
So melanoma crushing a basal layer?
Not
Probably
so much.
not, right? So Paget's or Bowen's.
Mm-hmm.
That's good for your differential. And this one happens to be a Paget's.
Okay.
But you could get, on H&E, you could get as far as Paget's versus Bowen's from that. Look for some clues. Fair number spitting out into the corneum. Okay.
Adjust the
They
settings
need
on
to
that
adjust the
to
settings.
stand.
Yeah, exactly. And that's in your user profile. You gotta, yep. So crushing of the basal layer, plus a fair number spitting out, maybe more likely Paget's than Bowen's. And if you feel a little bit on the spot with these and they're tough, that's okay, because so is real life and so is future exams, and you don't want that to be the first place where you're under the gun looking at a slide. So.
This looks like a keratoacanthoma to me.
Okay, so why KA?
You have some, looks like you have some micro abscesses at the base. Can't see really what type of cell is in the infiltrate, but you have buttressing with a normal epithelium. Looks
So
like there's some elastin trapping at the periphery.
Yeah, elastic trapping, some neutrophil microabscesses, glassy. Hard to make out hypergranulosis in the center. Looks like no acantholysis. So, agree. Crateriform. KA.
It's kind of like busy dermis type picture with a lot of clear cells.
Lots of clear cells.
Is this kind of like the paisley tie look that you can get sometimes? Sure. I see a lot of like strands.
Actually, some of them you could talk yourself into tasting.
Depends on what kind of paisley tie.
Where are you doing your tie shopping?
I know. James is going to show you some paisley ties.
Bubbles. Yeah.
Are the clear cells just in the dermis or in the epidermis as well?
Yeah, they're also in the epidermis.
Epidermis. So that limits your differential a little bit. It could be an epidermotropic tumor, or it could be something arising from the epidermis.
Yeah. I hear a lot of people saying it looks sebaceous.
So sebaceous would have micro vacuoles, so cells that have lots of tiny little vacuoles in them. Many of these to me look like they have one big vacuole that is more signet ring-like. Any stain that you might want for sebaceous differentiation?
EMA.
So EMA is probably the most readily available stain that you could do with that. And that one, EMA negative, and ultimately was a clear cell squamous. Arising in clear cell bones.
Could you have called that Vacuole?
I'm sorry, say it again.
Could you have called that one the Vacuole?
So you do all of those spaces look pretty clear. I didn't see anything that looked amphiphilic in the spaces, but mucicarmine stain would probably be very reasonable to do. Just to be sure that that's not what you're dealing with. Okay.
So it looks like we've got little islands of blue cells that seem to be coming off the epidermis overlying.
Yeah. Are the strands blue or are the strands pink?
You've got pink strands and some blue buds.
Pink strands and blue buds. Tell me about tumors with pink strands and blue buds.
You have a fiber epithelium of pincus, and then you could have a, was it infundibulocystic BCC?
And which one is this?
I think it's the BCC.
This is the BCC. So well, they both are types of BCC, I guess. So you were correct either way. Fibroepithelium of pincus, the strands anastomose like a net with lumps of the stroma in between, whereas infundibulocystic BCC is finger-like projections rather than surrounding the stroma. They project out into the stroma. So how about this one?
Looks like a pincus.
Looks like a pincus tumor. So this, just rather than fingers radiating outwards, these are anastomosing net-like network that traps the stroma. So those are your two pink strand, blue bud tumors. Yep.
So there is a lot of acanthosis.
Yeah.
A significant amount of keratinization in the stratum corneum. And here we're seeing some, I think there's some atypia within the epidermis.
So to judge that, number of mitoses we know doesn't really help. Atypical mitoses does help. And then you want to look at the nuclear envelope to see are there areas where it tends to be refractile and notched. Can you make V notching?
Yes, there's notching.
There's V notching. So that would be more real squamous epithelial atypia.
So, I mean, it's hard to tell if it's invasive because we're not seeing the...
So could the whole thing just be Bowens with massively enlarged rete or massively enlarged epithelium, follicular? And it could be. So you're absolutely right. You don't know that this is invasive going to the base. But it's probably a papillomavirus-induced Bowens. It has retained its round parakeratosis like a wart, whereas things like AKs have flat parakeratosis. This has round like a wart.
So, very pink, lots of keratin inside. Well, I guess the cut looks like a cyst, but really not.
So it looks like a cyst, but opens to the surface. More like a keratin-filled.
Yeah, like a KA.
Like a crater. And do you have hypergranulosis just at the periphery or all through?
Or the KA just in the center.
So KA extends to the center and a squame restricted just to the periphery of the tumor, the hypergranulosis. So those are nice scan clues that it's a keratoacanthoma.
Okay, so starting at the top, some compact cornified layers, and we have the epidermis, and it seems like coming off the epidermis is really a very infiltrative kind of blue-purple process. It would make me concerned about like an infiltrated BCC. Potentially it's going in between bundles of collagen as well as a lymphoid infiltrate.
So let's go back to the top.
Okay, so maybe like a little bit of an eyeliner sign there.
Like an eyeliner sign.
So some atypia as well, kind of going up.
Yeah, so what's your differential?
So for the eyeliner sign, I would think of Paget's or Bowen's.
Paget's or Bowen's.
Mm-hmm.
And then this one definitely giving rise to some kind of nasty carcinoma. You have lots of circles in the carcinoma, lots of little clear circles. So you might get
like an infiltrated, like Paget, like form of Paget's, or
like Paget's with an infiltrative adenocarcinoma. Underneath, you can get a mucicarmine to see is it really adeno-differentiation underneath. Bowen's would not produce an adenocarcinoma, so you wouldn't have mucicarmine positive ducts in it. So that could be one thing that could help. And in terms of behavior, this is going to behave with metastasis like an adenocarcinoma that's pretty big and deep. So, behavior is definitely going to be different from basal in terms of metastatic risk.
Sorry, Elston.
Yes, sir.
Does that atypia in the epidermis, do you think that's giving rise to the dermal process, or is it two separate? You're saying like the Paget, so then there's the adenocarcinoma, like separate?
That is adenocarcinoma arising from an extramammary Paget's.
Okay.
So Paget's is an intraepidermal intraepidermal adenocarcinoma, and the primary extramammary Paget's, they all arise along the milk line. So they're probably from primitive breast-like primordial germ cells that they're arising from, which is why it looks so much like Paget's of breast. And of all of the papers that try to distinguish immunohistochemically extramammary from mammary Paget's, much of the time you can't. And it's probably because it's all the same thing. It's just basically mammary, but arising from a primordial stem cell along the milk line rather than arising in a mature breast. Basal cell. Do you see any retraction space?
I don't, but some of the other cuts I felt like I was.
Do you have a concentric fibroblast-rich stroma?
I do.
Do you have large collections of plumped mesenchymal cells?
I do.
And what if this was sitting in a nevus sebaceous?
So yeah, the I don't understand the hair follicle name.
So trichoblastoma. So hints, throw that in because we're talking about basal cell. Basal cell is, that's going to be your daily sign out. Then a trichoblastoma hits. It's totally benign. How do you tell the difference? Lack of retraction and the stromal differences.
Even when it's arising off of the epidermis like that, so up in that area.
Correct. They can connect to the epidermis. So trichoblastoma, the key, lack of retraction space. It's going to be palisading blue cells. So the epithelium looks like a basal cell. How do you tell the difference? The stroma. No retraction space, not fibromyxoid, concentric, fibroblast-rich like the follicular sheath, and then papillary mesenchymal bodies out in the stroma. People have commented on my obsession with papillary mesenchymal bodies, but there's a reason. Okay.
Infundibular cystic basal cell.
Infundibular cystic, why?
Because there's the bed and the strand and the pink and the blue.
the buds and the strands and the pink and the blue and the horn cysts. Very good.
Let's say 30, Dr. Elston.
So let us do one more, and then we're done.
Well, there's no epi.
No epi. In fact, all of this stuff is
muscle, I think.
skeletal muscle. Right, so this is deep within skeletal muscle. And you have lymphoid aggregates, and you have new ropey collagen and spindle cells, and this whole thing is a squamous cell carcinoma. Every spindle cell you see is squamous cell carcinoma. So just as there are desmoplastic melanomas, there are desmoplastic squames that function like fibroblasts and make collagen. This was negative with a pan-keratin. So James, your stain was totally negative.
Poor stain choice.
Keratin 903 and P63, this was massively positive. Every last spindle cell all through the muscle. So monstrous desmoplastic squame, just like desmoplastic melanoma, collagen-producing spindle cells, lymphoid aggregates. This one, S100 and SOX10 negative, keratin 903, P63 positive. Okay, that's it. Let's get upload it.